Hello, team. We are going to be talking about the fascinating and ever so devastating subject of disseminated intravascular coagulation. If you guys know me, you know I get a little tongue twisted at times, so I will be referring this to as DIC. But it's important to know each of these. Disseminated means widespread, intravascular within the vessel, and coagulation. So this gives you a hint as to what we're going to be studying. Our objectives today are going to be to discuss the risk factors, etiologies, and pathophysiology of disseminated intravascular coagulation. We're going to describe assessment findings for the patient with DIC. We're going to explore diagnostic findings and the diagnosis of DIC, and we're going to design a plan of care for the client with DIC utilizing that nursing process. I bet you guys felt like you were done with anatomy and physiology, but you need to make sure that you that you always carry all of these with you. So if we can remember way back when to our clotting cascade here, we have the use of our platelets and phospholipids that occur after there's some endothelial damage within that intrinsic pathway, as well as all of these clotting factors listed below. As stage 2 occurs, we have our prothrombin activator, which activates the prothrombin in a positive feedback loop, creating our thrombin, And then in our third stage, with the help of our fibrinogen A, and loose strands of fibrin, we will eventually form a fibrin-type blood clot. Now, disseminated intravascular coagulation is defined as a widespread, aka disseminated, activation of the clotting cascade that results in a formation of clots in the smaller or those microvessels throughout the body. These small clots cause massive consumption of clotting factor, and as we are simultaneously expending all of these clots, we are bleeding throughout the body. This is a systemic process with the potential for causing thrombosis and hemorrhage all at once. During the normal clotting process, as you can see, we have our injury to that endothelial layer of the blood. At the initial stage, our vasculature will vasoconstrict to decrease bleeding. It will then normalize as our clotting factors come to the rescue, and a platelet slug forms. Then as our fibrin comes to the rescue, we have our fibrin mesh that forms. It's good visualization of the clotting process within DIC. So we have that overcoagulation. This is the activation of the coagulation cascade. It leads to production of thrombin, consisting of platelets and fibrin, often in that microvasculature. And then during the event of fibrinolysis, we have this activation at the sites of the thrombi with generation of fibrin degradation products, or FDP, and when in large amounts, interfere with platelet aggregation and fibrin clot formation. As these clotting factors deplete, we have no space to create no product to create any kind of thrombus in the rest of our body, and it will cause a massive hemorrhage. This is what I had just said in the last slide for those of you who are our visual learners. The clotting process in DIC, we have our end organ damage. So this tissue or organ damage occurs as a result of decreased perfusion, thrombosis, and or bleeding. So all three of these may occur, and they may result in significant morbidity and mortality. Here's some pathological manifestations that occur within DIC. We have our disseminated fibrin thrombi, which results in obstruction of blood flow that produces end organ ischemia. ischemia and necrosis. We have our activation of the kinin system, which causes vascular permeability, hypotension, and shock. If you guys remember on our burn slide with our capillary leak syndrome, that also caused some vascular permeability. Remember, everything ended up in that third space, right? So our vasculature is really severely compromised. We have activation of the complement system, which results in red cell and platelet lysis, increased vascular permeability, and shock. We have a release of cytokines. This includes interleukin 1 and 6 and tumor necrosis factor. Then we have our plasma-induced lysis of fibrin, our liberation of FDP, and further deletion of the coagulation factors, and this results in hemorrhage and shock. If you guys get to take nothing away from these slides, but one slide, I want you guys to remember that DIC is secondary to any underlying cause. So DIC is secondary to any underlying cause, or to these underlying causes. So when we treat DIC, we don't obviously can't forever replace all of these depletion of clotting factors for too terribly long. We have to reverse the cause there. And so some of these include sepsis, malignancy, trauma, obstetrical complications, which you guys have learned about in this quarter, intravascular hemolysis, heat stroke, crush injuries, amphetamine overdose, fat embolisms, vascular abnormalities, solid organ transplant rejection, antiphospholipid antibody syndrome, hereditary protein C deficiency, and blood transfusion reactions can even cause DIC. So as you can see, many of them are emergency complications or obstetrical complications, which is why we're doing this in this slide here. So there is no one way that we can diagnose DIC. We have to look at the entire kind of body, and usually DIC then gets diagnosed as kind of an after the event happens. But these are common laboratory findings in DIC. Might not see all of them, but these ones are common. We will have a decrease of all of these things: platelet count, our prothrombin time, activated partial thromboplastin time, our thrombin time, our plasma fibrinogen, our plasma factor 5, our plasma factor 8. Remember, all of these are getting expended. So they are getting overused, and they will either be decreased or prolonged. Two things may be elevated. This is our fibrinogen degradation product and our D-dimer. We'll go on to those in some subsequent slides here. So our D-dimer, this is an elevated D-dimer, it should be noted, may not indicate a presence of thrombus. There's lots of different reasons why we might have an elevated D-dimer, which I'll get to in the next couple of slides here. And it's important to know that elevations in the elderly patients may result in a false positive. So we have a lot more leeway for our elderly patients to have a higher D-dimer. That's just what happens within the body. They usually say 0.1 for each decade of life after age 50. So our 70-year-olds, we would actually tolerate a 0.7. That would be normal for them. On our 80-year-olds, a 0.8. Fibrinogen degradation products, this is leftover substances in the bloodstream after a thrombus has been broken down. So as you can see, why it would be elevated there. I want to talk a little bit more about D-dimer. It tends to fuddle people up. D-dimer is a protein fragment produced when a blood clot gets dissolved into the body, and it's detectable when there's a clot formation or when there's a clot dissolution in the body. Lots and lots of conditions that cause elevated D-dimer, including, one that we use quite frequently, which would be our pulmonary embolisms. But look at all of these other things that can cause that increased D-dimer. Clinical manifestations within DIC. Respiratorily, we will have a pulmonary hemorrhage, might manifest as hemoptysis or, the coughing of blood there. Might also have dyspnea and then ARDS as a final result there. Hepatic-wise or through our liver, the patient might show signs of jaundice or definitely impaired clotting factor production and clearance. Within the skin, these are late signs, unfortunately, so if we note these, then we're probably not doing well for our patient. These would be a purpuric and a petechial rashes, but it is interesting to know that they will have these. Within our central nervous system, we'll initially have transient symptoms, then delirium, and then coma. In our kidneys, we will have acute renal failure, adrenal hemorrhage, and then bleeding throughout, our catheters, drains, wounds, incisions, etc. So DIC, like I said, it kind of happens with all of these coming together, clinical and lab diagnosis. There's no single lab test that definitively diagnoses DIC, and then based on the findings of coagulopathy and the fibrinolysis is present if underlying risk factor conditions, in the presence of underlying risk factor conditions. So we definitely take our time to diagnose it, but formally, I should say. So then our treatment for these guys is going to be to treat the underlying causes. That's the most important thing that we can do. Then we will provide additional supportive measures such as hemodynamic support. Remember, with our third spacing, we don't have much tone in our vascular system once we third space, so we need to provide them with some fluid support, their ventilatory support, and then blood transfusions to introduce more of those clotting factors into the body. As we figure out the game plan there, this is just to buy us time, really. It should be noted that if blood transfusion reaction was the cause of the DIC, then we should not be giving them blood. We are going to prevent and treat any kind of bleeding. So if the patient is actively bleeding, we need to do all we can to control that hemorrhage there. And we might be giving them blood component replacement. These patients are at high risk for bleeding. We might have to do some prevention or treatment of a thrombus. So like I said, or I don't know if I said this in this one, but we can actually give heparin sometimes if the underlying cause is a thrombus. And it is kind of scary to give heparin to somebody that is actively hemorrhaging within their body, but that's going to treat that underlying cause, right? It's important to know that DIC does not immediately resolve once the inciting factor is corrected. It can actually take a few days for all of these coagulation factors to be reproduced within the body. So the patient is going to, still need the hemodynamic support, the ventilatory support, and the potential blood components in the meantime. Depending on the degree of DIC, mortality can range between 40 to 80% in patients with sepsis, trauma, or burns. So very, very, very high risk of mortality, morbidity there, and mortality and morbidity, I should say. And then the prognosis, as our age increases, we have a poorer prognosis. Prognosis also is determined by our severity of the organ dysfunction and our ability to reach hemostasis. Some nursing diagnoses for DIC include impaired gas exchange, ineffective tissue perfusion, and risk for bleeding. And thank you very much.